Hello and welcome to our recording today. Today we are looking at the anatomy of the reproductive system. Female reproductive system to be precise. Female reproductive system is a complex and interdependent system of internal and external organs that do work together for the purpose of sexual reproduction. So when you start by looking at the anatomy of the female genitalia. This is the vulva, and we have various parts, starting with the mons pubis, that is superiorly. This is a fat tissue, mons pubis or pubic. Then the clitoris, the outer lips, inner lips, the battling glands, the anus, vaginal opening, and bladder opening. So, just to share some information about these parts, starting with the mons pubis, this is a rounded and fatty tissue that is over the pubic bone, and it's usually covered with hair after puberty. So, and this is the region where we are going to be seeing this part, the mons pubis. Okay, the mons pubis. So the labia, this is followed by labia majora, then labia minora. The major difference between the two is that labia majora is more on the superficial side, outside part, the outside part. It's larger and it just consists of skin folds that do surround the vaginal opening that contain fat and the pubic hair. And this is the labia majora, guys. You can see the labia majora on this side and the labia majora on this side. They do unite anteriorly here, forming the mons pubis at that end. Next, we have the labia minora. They are still skin folds, but these ones, they are within the labia majoras. They are delicate, they contain nerve endings and the blood vessels, and they do enclose the vestibule. Next is the clitoris. This is small, highly sensitive organ, and it's here. It's here. This is the clitoris. Okay, it's compared to the penis for the male reproductive system. Okay, so in terms of its erectile tissue, it is so key for sexual arousal and pleasure. Then we have the urethral opening. This is where urine is normally expelled from the body and is located between the clitoris and the vaginal opening. And here is the opening, guys. You have here. Okay. All right. Next, we have the vaginal opening, have the perineum, fourchette, and the vestibule. And the perineum, guys, is the muscular area between the vaginal opening and the anus. Okay, so vaginal opening and the anus here, guys, this side. This is where we refer to this as the perineum, and it's very key when during the birth process. It assists in the process. Okay, while the fourchette, this is the region where the labia minora meet at the posterior end. Okay, so the fourchette is here where the labia minora meet at this posterior end is where we refer to it as the fourchette. The vestibule, on the other hand, is enclosed by labia minora, and it includes the opening of the urethra, the vagina, and it's very important for sexual function and the hygiene. So generally, the external female genitalia is referred to as the vulva or the pudendum. So, and it serves functions which are threefold. Number one is acting as a sensory tissue during sexual intercourse, especially the clitoris, and also assist in micturations by directing the flow of urine, and that is assisted by the urethral opening. And lastly, it protects the internal female reproductive system from the infections. This is usually facilitated by the vagina. Vagina is acidic and it's able to get rid of any microbes that is likely to infect the female reproductive system. So the vulva is a collective term for the for the several anatomical structures, including what you have already mentioned, the moon's pubis, which is up there. So you can see the mons pubis, the clitoris, then you have the clitoris, then the labia majora, labia minora, then I have now the vestibule, okay, which is consisting of the both the urethral and vaginal openings, then the labia minora, then the labia minora, they do unite posteriorly here, forming the fourchette, okay, and then the area between now the vaginal opening and the anus, this is what we refer to as the perineum, guys. Okay, we had already indicated the labia majora, they are just skin folds and they extend from the bones pubis posteriorly, okay, okay. Embryologically, they are derived from the lumboscrotal swellings. Okay, the labia majora, they are comparable to the scrotum for the male reproductive system. Labia minora, these are two hairless folds that do unite posteriorly to form the fourchette that you have said, and they also fuse anteriorly to form the hood of the clitoris and extend posteriorly of the side. They do emerge posteriorly, creating fold of the skin called the fourchette that you have already mentioned, and embryologically they are derived from the skin folds. Okay, so we can also see from this sagittal section of the body, and this is where we find the labium minus, labia minora. All right. Next, you have the vestibule. This is the area enclosed by the labia minora. It contains openings of both the vagina and the urethra. Okay, the vagina and the urethra, and that's what forms the vestibule. Okay, the vestibule for that matter. We do also have Bartholin glands in the external female genitalia, and their role is to lubricate, to secrete mucus that do lubricate the small ducts, especially during sexual arousal. They are located either side of the vaginal orifice. They are also known as greater vestibule glands, and sometimes they can be infected and inflamed, and this normally results in a condition that we refer to it as Bartholitis. Okay, Bartholitis. This is initially treated with antibiotics, but occasionally it can be complicated and it leads to formation of cysts or an abscess. So in case of an infected cyst or an abscess, the only effective treatment is normally the surgical drainage or the excision of the lesion. Okay, like you can see a right-sided Bartholin cyst caused by the blockage of the Bartholin glands or the greater vestibule glands. The clitoris, this one is located under the clitoris hood and it's formed by erectile corpora cavernosa tissue. This one normally becomes engorged with blood during sexual stimulation. Embryologically, they are derived from the genital tubercle, and you can be able to see. All right, great, great, guys. We have some conditions like the vulval warts. These genital warts, they are normally benign growths of the epithelium that they are caused by certain human papilloma virus types, especially type 6 and type 11. They are highly infectious and are easily transmitted between sexual partners, and this is majorly through sexual or physical contact. However, they do not evolve into cancerous lesions. But we have other strains of HPV. The most common one being type 16 and type 18. This may predispose affected individuals to dysplastic changes in the cervix, the vagina, and sometimes the anus, or both, which can potentially lead to carcinomas. Luckily, we have the recently developed HPV vaccines, and these vaccines are safe and are efficient in preventing high-risk HPV infections. We encourage, especially female of this the teenagers, they can get these injections so as to be able to be protected. When you look at vascular supply and lymphatics, you find that the arterial supply to the vulva, this is the external genitalia, is from the paired internal and external pudendal arteries, which are branches of the internal iliac artery and the femoral artery, respectively. Guys, a link on the abdominal aorta will be popping up. You can review the branches of the abdominal aorta to see how the pudendal arteries come up. When you look at the venous drainage, this is normally achieved by the pudendal veins with smaller labial veins contributing as tributaries. So lymph drains to into the nearby superficial inguinal lymph nodes for it to add up to the venous drainage. In terms of nerves and innervation, the vulva receives sensory and parasympathetic supply. To describe the sensory distribution, the vulva can be described into two regions. We have the anterior and the posterior sections. Yeah, anterior and the posterior sections. So when you look at the anterior section, we'll have the ilioinguinal nerve, the genital branch of the genitofemoral nerve. Okay, and here are the two. But when you look at the posterior, we have the pudendal nerve. Okay, the pudendal nerve is here, and you can see its branches. We also have the posterior cutaneous nerve of the thigh. Okay, nerve of the thigh, which is here, and you can also see its branches. So the clitoris and the vestibule also receive parasympathetic innervation from the cavernosous nerves, which are derived from the uterovaginal plexus. So that marks the end of the external female genitalia. From now, we can look at now the internal female reproductive system, which consists of the female reproductive tracts, starting with the vagina, endometrium, cervix, uterus, fallopian tubes, and the ovaries. So both the vagina and the cervical cap are commonly referred to as the birth canal, and now we have the site for the implantation, that is the uterus. Okay, then we have the ovaries that do participate or support this vital process by producing the ovum. Then you have the site for fertilization, the fallopian tubes, especially the ampulla. Okay, where fertilization commonly happens before it travels to the isthmus into the uterus for implantation. So we can start with the vagina, and this is an organ of the female reproductive tract. It is a distendable muscular tube, and it does extend posterior superiorly from the external vaginal orifice in the vestibule up to the cervix, and it does carry out several roles within the female reproductive system. Number one role is for sexual intercourse. As you know, the vagina is the one that is responsible for receiving the penis and the ejaculate. So this helps assist in transport of this ejaculate to the uterus. Number second role is the childbirth, and the vagina normally expands to provide a channel for delivery of a newborn from the uterus. Lastly, vagina is very important during the process of menstruation, as it serves as a canal for menstrual fluid and tissue that normally leaves the body. So that makes it so important. Anatomically, in terms of positioning, you find that it's closely related to many organs in the pelvic region. Anteriorly, we have the bladder and the urethra. Bladder and the urethra. Remember, the vagina is here, so we have the bladder and urethra anterior to the vagina. Posteriorly, you find that we have the rectouterine pouch and rectum and the anal canal, and you can be able to see them on our diagram here. And laterally, we have the ureter and the levator ani muscles. So that is how the vagina is positioned. So the vagina is a fibromuscular tube with anterior and posterior walls These are normally collapsible and thus they are normally in contact with each other. So the shape of the vagina is not a round tunnel as many of you think. Instead, when you look at it in transverse plane, it's more like a H, okay? A H lying on the side. A H lying on the side. Can we go to see here, guys? Okay. Look at it from the posterior side. So it's a H line, it's not round tunnel as most of us normally think. So at the upper endings, the vagina surrounds the cervix, okay, the cervix. So and this one leads to creation of two domes. We have the anterior dome. You can be able to see on my diagram, and the posterior dome you can be able to see. So this posterior dome or posterior fornix is very important because it normally acts as a natural reservoir or storage for semen after intravaginal ejaculation. So you'll find it here. So the semen is retained in this fornix and it normally liquefies in the next 10, 20 to 30 minutes, and this allows for easier permeation through the cervical canal, and that is so important for the posterior dome. Histologically, the vagina is composed of four histological layers. If you look at it from internal to the external surface, we have the stratified squamous epithelium. This layer provides protection and it's lubricated by the cervical mucus. That is, the vagina itself does not contain any glands. Okay, so the mucus comes from the cervix, followed now by the elastic lamina propria. Okay, and this lamina propria is a dense connective tissue layer which protects the papilla into the overlying epithelium. So the larger veins are located here in this elastic lamina propria. Thirdly, we have the fibromuscular layer, and this comprises of two layers of smooth muscles. We have the inner circular and the outer longitudinal layer. And then lastly, now we have the adventitia, and this adventitia is a fibrous layer which provides additional strength to the vagina while also binding it to the surrounding tissue. So that's how histologically the vagina is divided. In terms of vascular supply and lymphatics, we have the arterial supply to the vagina is normally by the uterine and the vaginal arteries. Both of these are just branches of the internal iliac artery. Venous return is by the vaginal venous plexus, which do drain into the internal iliac veins via the uterine vein. For the lymphatic drainage, it's divided into three sections. We have the first section, which is the superior, which drains into to the iliac external iliac nodes. Then you have the middle one, which drains to the internal iliac nodes, and then the last one, the inferior one, which drains to the superficial inguinal lymph nodes. And you can be able to see the posterior view of the arterial supply uh, to the femoral tract, and you can see internal iliac artery coming up with branches that are vaginal arteries that do supply the vagina. Then you have the uterine artery also. It also supplies it. Then above it, you can see the ovarian artery. In terms of innervation, the innervation is predominantly from the autonomic nervous stimulation. So parasympathetic and sympathetic nerves do arise from the uterovaginal nerve plexus. This is internal subsidiary of the inferior hypoglastic plexus. So it's good to know that only the inferior part, which makes about a fifth of the vagina, receives somatic innervation. Okay, so this is via the branch of the pudendal nerve, the deep perineal nerve for that matter. Okay, and I can be able to see that the pudendal nerve, the uterovaginal plexus. Okay, fine. So it has some clinical significance in that we normally have what we say vaginal fistulae or obstetric fistulae. Okay, and a vaginal fistula is just an open communication between the vagina and one of its adjacent pelvic organs. It could be the urethra or the anus. Okay, so um, this vaginal fistulae commonly occurs as a result of prolonged labor, and this happens in places where cesarean section is not available. So, as the fetus slowly progresses down the vaginal wall, it normally exerts a pressure, and this obstructs the blood supply, causing tissue to necrose in that region. So, in short, we have three main types of vaginal fistulae. We have the vesicovaginal fistulae, the ureterovaginal, and the rectovaginal. Remember, we said that the definition of a fistula is an open communication between the vagina and the adjacent pelvic organ. So, for the vesicovaginal, is an abnormal connection between the bladder and the vagina. So what happens? The bladder, it's the storage for urine. So if there's a connection between the vagina and the bladder where urine is supposed to be stored, it means that now urine will be entering the vagina instead of being stored in the bladder. What about the ureterovaginal fistulae? This is an abnormal connections with the urethra, the vagina and the urethra. So it is ureterovaginal opening. So what happens with the urethra? Of course, when you want to pee, that urine has to get to the urethra. Okay? Okay. When you want to do what? When you want to pee, when you want to remove the urine. So one of the striking feature for this kind of problem is that you will be having urine will be entering the vagina when you are urinating. When you are urinating, you will be getting the urine. That makes it it's a classic sign for the ureterovaginal fistula. Lastly, we have the rectovaginal. Rectum is an abnormal connection between the vagina and the rectum. So what happens? You find that now the rectum normally has the fecal matter. So fecal matter can enter the vagina. That means you have a rectovaginal fistula. From the vagina, we get to the cervix. All right. From the vagina, we get to the cervix. And this is the lower portion of the uterus. The uterus is just superior here, up here. And the cervix, it connects the vagina with the main body of the uterus. And it acts as a gateway between the two. Okay, between the two. If you want to get to the uterus, you have to pass through it has to pass through the cervix, all right? So it's a gateway, okay? It's the neck, okay? The neck, guys. Anatomically and histologically, the cervix is distinct from the uterus. You have to know that. You find that the cervix is composed of two regions. We have the ectocervix and the endocervical canal. So the ectocervix is the portion of the cervix that projects into the vagina. So you move from the vagina to the ectocervix, then endocervical canal. Okay, so this ectocervix, the one that is connected to the vagina, it's lined by stratified squamous non-keratinized epithelium, and the opening in the ectocervix is the one that we normally refer to as the external os, and this marks the transition from the ectocervix to the endocervical canal. The endocervical canal, on the other hand, or the endocervix, is more proximal and it's the inner part of the cervix. Okay, here, guys, you can see the external os. Then we have now the endocervical canal. And then lastly, we have the internal os before you get to the cervix. So, the endocervix is lined by mucous secreting simple columnar epithelium. The endocervical canal ends and the uterine cavity begins at this narrowing called the internal os. So after the internal os, now we can get to the we can get into the cervix. The functions of the cervix are majorly two. One is to facilitate the passage of the sperm into the uterine cavity, and this is normally achieved via dilation of both the external and the internal os. Number two, we have maintaining sterility of the upper reproductive tract. You know, the cervix and all structures superior to it are sterile. Okay, so this ultimately protects the uterine cavity and the upper genital tract by preventing bacterial invasion. So this environment is normally maintained by the frequent shedding of the endometrium, where we have thick cervical mucus and then a narrow external os. So that helps maintain the sterility. Can be able to see the ectocervix, guys. This is very common when you are carrying out the via villi process. You'll be able to see the ectocervix. In terms of vascular supply and lymphatics, the blood supply to the uterus is, uh, to the uterus is normally via the uterine artery, and we have venous drainage is via the plexus in the broad ligament that drains into the uterine veins. So the lymphatic drainage of the uterus is normally via this iliac, sacral, aortic, inguinal lymph nodes for that matter. Okay, so we have disorders of the cervix, and we could have like cervicitis and cervical cancer, which are the most common one. Okay, so cervicitis, this is chronic inflammation and infection of the cervix, and it's mostly by these two species, the chlamydia trachomatis and Neisseria gonorrhoeae. It is usually asymptomatic, so the patient will not be showing the signs and symptoms, although pelvic pain, vaginal discharge, postcoital bleeding, and dyspareunia may be present. So complication of this cervicitis will include pelvic inflammatory disease, PID, while the potential blockage of the mucus ducts and cyst formation increases the risk of infertility by increasing the hostility of the environment for the sperm. Okay, next we have the cervical cancer, and there are two main classifications of this cervical cancer. We have the squamous cell carcinoma. This is cancer of the epithelium lining of the ectocervix. And we have the adenocarcinoma, the cancer of the glands found within the lining of the cervix. All right. So infections of the female genitalia with this HPV, human papilloma virus, is widely known as the major cause of majority of the cervical cancer. But thanks, we have this vaccination that we have already mentioned, that female teenagers, they need to be vaccinated using those vaccines for the HPV vaccinations. Next, we have the uterus, and from the cervix, we go to the uterus, guys. From the vagina, we travel to the cervix. Now we are in the uterus, and the uterus is what? It's a secondary sex organ. What does secondary sex organ mean? We say that secondary sex organs are components of this reproductive system that normally mature during puberty under the influence of sex hormones produced from the primary sex organs. And this is the ovaries in females and the testes in males. So the uterus, these are responsible for the maintenance and transportations of gametes for that matter. All right. Okay. Anatomically, you find that the uterus is a thick-walled muscular organ capable of expansion to accommodate a growing fetus. The growing fetus normally develops in the uterus. So we have the fundus, we have the body, and then we have now the cervix. Of course, we have already talked about the cervix. So let's concentrate on the uterus. The uterus is connected distally to the vagina, right? And laterally to the uterine tubes. So the uterus has three major parts. We have the fundus, which is at the top of the uterus, above. This is the above the entry point of the fallopian tubes, right? Okay, and the body now. The body is usually the site for the implantation. Okay, remember the blastocyst has to move from the fallopian tubes to the uterus for implantation, and When the implantation happens, the endometrium ceases to be referred to as the endometrium and it's referred to as the decidua. Okay? So, and the exact point of implantation is what we normally refer to as the decidua basalis. Right? The decidua basalis. Another part, key part of the uterus is what we have already talked about, the cervix, and this is the lower part of the cervix, and it does link the uterus to the vagina. Okay, this part is structurally and functionally different to the rest of the uterus. Anatomically, the exact location of the uterus varies with the degree of distension of the bladder. But in a normal adult, the uterus can be described as anteverted, okay, with respect to the vagina, and anteflexed with respect to the cervix. Okay, so the vagina and the cervix are very important. So anteverted, it means it's rotated forward towards the anterior surface of the body. Anteverted. Okay, yeah, be able to say that, anteverted. Whereas anteflexed, it means that it has flexed towards the anterior surface of the body, right? That's flexed and towards the anterior surface of the body. So thus the uterus normally lies immediately posterior superior, okay, to the bladder. Okay, so where is the bladder, guys? Posterior, you're saying it's normally lies posterior superior to the bladder. So the bladder is here, guys. You can see the uterus, which is here, is behind. Okay, it's behind the bladder, but it's superior. It's above the bladder. That's why he's saying it is posterior superior. Okay, and it is anterior to the rectum. Anterior to the rectum, guys. The rectum is here. Okay, and the uterus is here. So the uterus is anterior to the rectum. I hope you understand there, guys. Thank you. So we have abnormal positioning of the uterus. So in some individuals, the uterus may not lie in anteflexed and anteverted position. So there are three most common dispositions, which are excessively anteflexed, antiflexed and retroverted, retroflexed and retroverted. These abnormal arrangements do not inherently cause any medical problems. However, you find that the retroverted uterus is positioned directly above the vagina. Okay, so thus you find that when that happens, the instances of increased abdominal pressure find the uterus may likely prolapse through the vagina. So retroverted uterus gives us that risks. Whereas the uterine prolapse is particularly prevalent in those with a history of damage to the pelvic floor. Okay, pelvic floor damage, the incidence of prolapse will be high. Okay, guys. So in our diagram, we have the normal position, we have the anteverted, we have the retroverted, we have the retroflexed. Okay, so in a normal position, you can be able to see our uterus because it's anterior to the bladder. It's anterior, it's not interior, but it is posterior to the bladder. Okay, and so it is posterior superior. It is posterior to the bladder but above the bladder, and then it's behind. It's anterior to the rectum. So the rectum is behind. You can be able to see that. So in a normal uterus, this is how it will happen. But in anteroverted, you can see it's excessively traverted. While the retroverted, you can see it is above the vagina. So we are saying that there's a highly chance that it will prolapse. Okay, this is the normal position, Now this is the abnormal position. Okay. The introflexed, now you can be able to see now how it shapes. So those are the abnormal positions of the uterus. Histologically, find that the fundus and the body of the uterus are composed of three tissues in layers. You have the most outside one, the middle one, and the innermost one. The most outside one is the peritoneum. This is a double-layered membrane and is continuous with the abdominal peritoneum. So it is also known as the perimetrium. All right, perimetrium. Myometrium is the second one. This is a thick, smooth muscle layer. So cells of this layer undergo hypertrophy and hyperplasia during pregnancy in preparation to expel the fetus at birth. Okay, the muscles. Then lastly, we have the endometrium. This is the inner mucous membrane that lines the uterus. It can further be divided into two parts. We have the deep stratum basale and the superficial stratum functionalis. So the deep stratum basale changes a little throughout the menstrual flow and is not is not shed at the menstruation, while the superficial stratum functionalis proliferates in response to estrogen and normally becomes secretory in response to progesterone. It is shed during menstruation and it regenerates, okay, from the cell in the stratum basalis layer. So this uterus is kept in position by a number of ligaments. So the tone of the pelvic floor provides the primary support for the uterus. Some ligaments provide further support, securing this uterus in position. And they are broad ligament. Okay, so the broad ligament is a double layer of the peritoneum that normally attaches the sides of the uterus to the pelvis. It acts as a mesentery for the uterus and contributes to maintaining it in position. While the round ligament, okay, the round ligament is a remnant of the gabaculum extending from the uterine horns to the labia majora via the inguinal canal. It functions to maintain the anteverted position of the uterus. We have the ovarian ligament. The ovarian ligament joins the ovaries to the uterus. Okay, the joins ligament. Remember, this is the ovary. This is the uterus, so it joins. Okay. Okay. So next we have the cardinal ligament, and this one is located at the base of the broad ligament. The cardinal ligament does extend from the cervix to the lateral pelvic walls. It contains the uterine artery and the vein in addition to supporting the uterus. So that's how this ligament can be important. Uterosacral ligament extends from the cervix to the sacrum. So it provides support to the uterus. The blood supply to the uterus is via the uterine artery, and venous drainage is via the plexus to the broad ligament that drains into the uterine veins. For lymphatic drainage of the uterus is via the iliac, sacral, aortic, and inguinal lymph nodes for that matter. So we have a procedure by the name hysterectomy, and hysterectomy is a surgical removal of the uterus, and it could be as a result of either cervical or uterine cancer. So when performing hysterectomy, a good knowledge of regional anatomy is very key to prevent accidental damaging of these adjacent structures in the pelvic region. So the uterine artery normally crosses the uterus approximately 1 centimeters laterally to the internal os. So care must be taken not to damage the uterus during the clamping of the uterine arteries during a hysterectomy. The relationship between the two can be remembered using this phrase that we normally say, water under the bridge. So water refers to the ureters, to the ureter, that's urine, and the uterine artery is the bridge. Okay, correct. In terms of innervation, we have the sympathetic nerve fibers of the uterus arising from the uterovaginal plexus. This largely comprises the anterior and intermediate parts of the inferior hypoglossal plexus. Parasympathetic fibers of the uterus are derived from these pelvic splanchnic nerves, the S2, S4. The cervix is largely innervated by inferior nerve fibers of the uterovaginal plexus. The afferent fibers mostly ascend through the inferior hypoglossal plexus to enter into the spinal cord via the T10, T12, and the L1 nerve fibers. So we have a number of disorders that does affect the uterus, especially the endometrium, that's the inner lining. And one of the key condition is endometriosis. This is just the presence of ectopic endometrial tissue at the sites outside the uterus. Most commonly the ovaries and the ligaments of the uterus. So ectopic tissue is still responsive to oestrogenic stimuli. Therefore, cyclic proliferation and bleeding can occur, often forming a cyst. So this condition is associated with dysmenorrhea and infertility of both. Another condition, we have the fibroids. These are benign tumors of the myometrium. Okay, so the myometrium is affected, and this is about 20% of menopausal women. So these fibroids are estrogen dependent, so they do enlarge during pregnancy and with the use of contraceptive pill, but will regress after the menopause. So most fibroids are asymptomatic, which means patients do not show any symptoms. But if they enlarge enough, they are large enough, the uterine mass can cause symptoms which could include menorrhagia, pelvic pain, and infertility. Lastly, we have endometrial carcinoma, which is the most common malignancy of the female genital tract. This is the most often found during or after the menopause and is characterized by abdominal uterine bleeding, endometrial carcinoma. So from the uterus, we go now to the uterine tubes, the fallopian tubes, and they're also referred to as the salpinx. Okay. So these are muscular, they are J-shaped tubes. They lie in the upper border of the broader ligament, and they do extend laterally from the uterus, opening into the abdominal cavity near the ovaries. We have these, the fallopian tubes. They are a pair. And the major function of the uterine tubes is just to assist the transfer and transport of the ovum from the ovary to the uterus. You have the ultrastructure of the uterine tubes, which facilitate the movement of this female gamete. So we have also the inner mucosa, which is lined with ciliated columnar epithelial cells and PEG cells. The PEG cells, these are just non-ciliated secretory cells. So they waft this ovum towards the uterus and supply it with the nutrients. Smooth muscle layer, it will contract to assist in the transportation of the ovum and the sperm. So muscle is very sensitive to sex steroids, and thus peristalsis you'll find it's greatest when estrogen levels are high. Anatomical position, we find that these fallopian tubes can be described having as four major parts, and these major parts we are moving laterally to medial. Okay, the most medial part, of course, we know is the isthmus. Then we have the then from the isthmus, which is medial, we can now go laterally to the ampulla. This is the major site for implant for fertilization. Then we have the infundibulum. Then lastly the fibri. Okay, so the fibri, these are just finger-like ciliated projections which capture the ovum from the surface of the ovary. Okay, capture it. All right. And then the infundibulum, this is a funnel-shaped opening near the ovary to which the fibri are attached to. Then the ampulla, we have this, the widest section of the uterine tubes. This is where fertilization usually occurs in this ampulla. Then the isthmus, this is the narrow section of the uterine tubes. This connects the ampulla and the uterine cavity. Vascular supply and lymphatics, the arterial supply to the uterine tubes is via the uterine and ovarian arteries, while venous drainage is via the uterine and venous veins. The lymphatic drainage, on the other hand, is via the iliac, sacral, and aortic lymph nodes for this case. The innervation, the uterine tubes, they do receive both sympathetic and parasympathetic innervation via the fibers from the ovarian and the uterine plexus. So we have sensory afferent fibers which run from T11 to L1. We have a condition by the name salpingitis. What is salpingitis, guys? Salpingitis is the inflammation of what we are talking about, the uterine tubes, the fallopian tubes. Remember, they are also referred to as the pharynx. So that's usually caused by bacterial infection. It can cause adhesions of the mucosa, which may partially or completely block the lumen of these uterine tubes, and this can potentially result in infertility or ectopic pregnancy. And ectopic pregnancy is another condition that's associated with salpingitis. All of these conditions do affect the fallopian tubes. So if the lumen of these uterine tubes is partially occluded, so sperm may be able to pass through and fertilize the ovum. However, now the fertilized egg may not be able now to pass into the uterus. All right, because the sperm is the smallest cell of the body. Of course, we all of us know the ovum is slightly large. Okay, of course, it's the largest cell in the human body, so it can't pass to get back to the uterus. So it implants into the uterine tube, and when such an instance happens, this is referred to as ectopic pregnancy. So ectopic pregnancy is a medical emergency, and if not diagnosed early, the implanted blastocyst can cause rupture and hemorrhage of the affected tube. Okay. Another key clinical significance procedure that normally happens, especially that affects these fallopian tubes, is the ligation of the uterine tubes. Find the surgical cutting of these uterine tubes has also been considered as a method of sterilization, not able to give birth to more children. So the oocyte is unable to pass into the uterus, okay, and therefore cannot progress to pregnancy. There are normally two major methods of ligation. We could have open abdominal ligation. This is normally carried out via a suprapubic incision just above the pubis. And then we have a laparoscopic. This is carried out by a fiber optic laparoscope, which is normally inserted via a small incisions near the umbilicus. So the main functions of the ovaries, which forms as the next part after looking at the fallopian tubes, we now look at the ovaries. The ovaries is to produce oocytes. So these are female gametes in preparation for fertilization. So the ovaries also do assist in production of sex steroid hormones, the estrogen and progesterone, in response to pituitary gonadotropins, which is the LH and the follicle stimulating hormone and luteinizing hormone. So the ovaries, we all know these are female gonads. So in both male and female, the gonads normally develop within the mesophrenic ridge and descend through the abdomen. However, unlike the testes, the ovaries, they stop in the pelvis. Remember, if you have undescended testes, we normally refer to as that condition as cryptorchidism. But for the ovaries, they do stop in the pelvis. So the ovaries are paired. They are oval organs, and they are attached to the posterior surface of the broad ligament of the uterus by the mesovarium. This is just a fold of the peritoneum that is continuous with the outer surface of the ovaries. So the neurovascular structures, they do enter the hilum of the ovary via the mesovarium. We have components of the ovary. So we have majorly three parts. We have the surface, which is majorly composed of the cuboid or simple cuboidal epithelium, also known as the germinal epithelium. and this is the underlying this layer with a dense connective tissue capsule. Then you have now the cortex. The cortex is comprised of connective tissue stroma and numerous ovarian follicles. Okay, they contains numerous ovarian follicles. So each follicle contains an oocyte, surrounded by a single layer of follicular cells. Lastly, we have the medulla, and the medulla is formed by loose connective tissue and a rich neurovascular network, which enters via the hilum of the ovary. And those are the components of the ovary. We have some disorders that do affect, but maybe before that I could give you the lymphatic supply. You find that lymph from the ovaries, they normally drain into the para-aortic nodes. So studies have found that we normally have two major and one minor lymphatic drain pathway of the ovaries, starting with the abdominal pathway, which runs via the infundibulum pelvic ligament to the para-aortic, that's the left side, and the paraclavicle, the right side regions. Then you have the pelvic pathway and the inguinal pathway that normally drains around the round ligament of the uterus to the inguinal regions. So these ovaries are also affected by some conditions, and one of the major conditions that do affect the ovaries are the ovarian cysts. When you talk of ovarian cysts, these are just fluid-filled masses that develop in the ovary. They are most common derived from the ovarian follicles, and they could reach approximately 2.5 centimeters. You find most ovarian cysts are benign and develop during a woman's childbearing ages. However, some larger cysts may cause problems such as bleeding, pain, or require surgical removal. Then we have now polycystic ovaries, and polycystic ovaries are just characterized by hormone dysfunction and multiple ovarian cysts, and we have over ten cysts. We are now talking of polycystic ovarian ovaries. It's associated with infertility, and you can be able to see my diagram on my right, an image of a polycystic ovary. This is how the ultrasound will appear. Next, we have the ovarian tumors, and these are another serious disorder. So the most common cancers do arise from the epithelial components of or the germ cells. So 90% of these ovarian cells are derived from the epithelium. So these are termed as ovarian adenocarcinomas. Most germ cells tumors are teratomas, which comprise cells from all three germ layers and are usually benign. We have the ligaments of the ovaries, and we have two peritoneal ligaments which do attach to the ovary. We have the suspensory ligament of the ovary. This is just a fold of the peritoneum extending from the mesovarium to the pelvic wall, and it contains neurovascular structures. On the other hand, we also have the ligament of the ovary, and the ligament of the ovary extends from the ovary. Okay, it extends from the ovary to the fundus of the uterus. It then gives rise to the uterus to the connective tissue of the labia majus, and as they're now the round ligament of the uterus. For the neurovascular supply, the main arterial supply to the ovary is via the paired ovarian arteries. They do arise directly from the abdominal aorta. Uh, that is the inferior to the renal artery. So there is also a contribution from the uterine arteries. They also supply these parts. On the venous drainage, it's achieved by paired ovarian veins. So the left vein drains into the left renal vein, while the right ovarian vein drains directly into the inferior vena cava. So the ovaries do receive both sympathetic and parasympathetic innervation from the ovarian and the uterine plexus respectively. The nerves do reach the ovaries via the suspensory ligament of the ovary so as to enter the ovary at the hilum. All right. Okay. So So guys, that marks the end of our presentation on the on the female reproductive system, and we have said that it majorly consists of the both the external and the internal tract. So the external is the vulva, while the internal forms the tract, and we have looked at the tract starting from the vagina, going to the cervix, going to the uterus. Then we've looked at the fallopian tubes, and then finally we have looked at the ovaries. Thank you so much, and thank you for listening.